Friends, we are welcoming you to this poster podium presentation. And we have each speaker who is going to be allotted only 4 minutes. You know the rules of the game, yeah? And we would definitely request you all to stick to time. Don't introduce yourself. I mean, there's been Sagarika, I'm Sagarika also, so maybe it doesn't matter. But the important thing is stick to time and present your cases well. And we ought to learn from each other. And I'm definitely there to learn from Professor Sangwan and from all of you. So go ahead, girls. The next speaker who's on the list, please be ready at the next podium so that we don't waste any time whatsoever, right? And we might have just about one question per person. And I definitely would want and request to request Professor Sangwan to share his pearls of wisdom, which are fantastic. And I've known him for so many years. And so it's fantastic here to have him here. In fact, I feel very awkward sitting beside him. I want to sit somewhere there. Okay, right. So, young lady, please, my namesake, go ahead.
Good afternoon, everyone. Today's my topic is magnitude of dry eye among medical students and its impact on their mental health. As we know, dry eye has become the more prevalent condition affecting worldwide. Its prevalence varies between 5% to 30%. Approximately 25 to 30 million people are affected by dry eye all over the world. The symptoms are ocular discomfort, irritation, itching, fatigue, foreign body sensation, photophobia, pain, burning sensation, and mucus discharge. Dry eye also had an impact on psychological and mental health like anxiety, depression, sleep disorder, and mood disturbances. We studied a cross-sectional questionnaire-based study was conducted among 350 medical students over a period of 3 months. A well-designed performer was prepared consisting of demographic details, contact lens uses, duration of electronic device usage, and extraocular and ocular symptoms were noted, along with a validated questionnaire of Ocular Surface Disease Index, that is OSDI, and Hospital Anxiety and Depression Scale were reported for subjective analysis of dry eye disease. And graded, classified according to the given grades, and we excluded the patient with any ocular surface disorders. The results are, in our study, from 350 students, 171 were males and 179 were females. The mean age was 22.7 years and 15% of them were contact lens users. As we can see, as the OSDI grade increases, the severity of dry eye increases. There is also a abnormal anxiety grade, and same for the depression also. It can occur at any age group, more commonly in adults. Medical students are prone to dry eye due to the prolonged use of laptops, computers, cell phones, and projector for their academic activities. We compared our study by Tuladhar et al. We found the similar results in that study also. Among extraocular symptoms, headache was reported by various studies that were similar to our study, and in various factors. It was also found in various literature that dry eye disease may affect the mental state of the individual. We reported 22% and 16% students of borderline and abnormal anxiety disorder, and 14.9 and 13.7 had a borderline and abnormal results for depression grading respectively. The prompt treatment for dry eye is a key factor to avoid complication. Various studies had been conducted in the past, but none of them showed an association between dry eye and dysfunctioning of mental health in medical students. In our study, we tried to highlight the problem faced by young population these days and making them aware of computer vision syndrome and its impact on their mental health. Thank you.
The question I have for you is that how do we know these medical students have an anxious predisposition and then develop dry eye, not the other way around?
Okay. So
can this study answer that question, or is it?
No, sir. We just take a cross-section study. So we just prepare a pro forma, which includes both the scales of that OSDI and hospital and anxiety, and on the basis of history taking, and only that we have done.
Generally, people who are
predisposed to,
they are likely to have dry mouth.
Okay.
Because of their parasympathetic and autonomic nervous system overactivity.
Yes.
Thank you.
Thank you. Yes.
So she's my student. I should not be marking her.
अब तो नहीं है ना
अब तो नहीं है.
नहीं
अब तो
now?
नहीं है.
All three are my teachers today. Good morning, everyone. So, scleritis, coming directly to the presentation of infectious scleritis. So, scleritis is a painful state of ocular inflammation which causes destruction, and the clinical features and etiology is such that it mimics immune-mediated scleritis, and so it is very difficult to identify these cases. So, the epidemiology in developing nations, what we have, slides are not moving. So in developing nations, we have seen that the incidence of infectious scleritis is higher, around 18 to 30%, and the most common cause is fungal, and it is identified in the younger male population. The mode of infection goes from exogenous to endogenous variety. The exogenous being most commonly the surgical trauma, post-surgery, or trauma from vegetative matter, or spread from adjacent ocular inflammation. And these cases have more greater severity of tissue damage. And the endogenous causes are systemic illness like tuberculosis, herpes, or syphilis, and these mimic more of immune-mediated variant. So there are various studies reported from India which show that surgery has been the most common cause and fungus and bacteria have been higher in the list. So I'll be presenting two cases. The first case is a 58 years old male farmer who complains of pain and redness since 7 months, and there was no history of trauma or surgery. He's a known case of diabetes, and he was diagnosed elsewhere as immune-mediated scleritis, and he was treated with topical and systemic steroids. So you can see in the pictures that there was a superonasal infiltrate around 5 into 5 millimeters there were exudates upon the iris, and there was a streak hypopion. So we planned for a corneal scrapings, and we found budding yeast cells with pseudohyphae. Now, and in the last picture, you can see there was a nodular lesion which was there around 4 to 5 millimeters superior, and there was an area of thinning besides that lesion. So we decided on scleral wound exploration in this patient. And to our shocking, we found two foreign bodies which are there in the superior picture. And these are the pictures of the yeast hyphae. So we started the patient on antifungals, oral as well as systemic, and we obviously stopped the steroids, and the patient resolved very well. My second case is a patient who again complained of pain in the left eye for 3 months, again with no history of trauma and surgery. And she was also treated as immune-mediated scleritis. The patient was also on azathioprine for 3 months. And this patient, as you can see in the pictures, she came with diffuse involvement, diffuse congestion, and there was some area of nodular congestion on the nasal side. So we started the patient on oral NSAIDs and topical steroids, considering it to be immune meteorology. But after 2 weeks, when the patient presented to us, this was the picture. So there was a nodular area which was looking a little purulent. So we planned for scraping with scleral exploration, and we found GPC on the smear. So we treated the patient with antibiotics, and we can see that there was progression of the nodules, and there was migration of these nodules in various quadrants. And so we repeated the scleral biopsy, finding it to be nocardia. Then we treated the patient with amikacin and sulfamethoxazole and trimethoprene. After 3 weeks, we started the patient on prednisolone eye drops, and there was resolution in 5 months. So I'll skip this. At the end, I want to conclude that it is important to differentiate between immune-mediated and infectious. So infectious always presents as immune-mediated, and most of the times if the patient doesn't give any history of trauma or there is not an obvious sign of infection or a corneal lesion, so we should be very careful and meticulous screening, and repeated biopsies might be required to come to a diagnosis. Thank you. Yes.
So would scleral thinning or scleromalacia still you would go ahead with biopsy in those patients?
Yes.
Is it a sign of previous biopsy?
That was a sign of previous biopsy. So the patient might have undergone biopsies elsewhere. We don't have the exact literature of that patient. Even the second patient underwent biopsy elsewhere, but still did not reveal any organisms. So we managed the patient as immune mediated in the second attempt. But both these biopsies, there can be scleral thinning, and you have to be very careful. And AMG can be used as one of the options. In
So,
second,
I mean, in your study, in this case series, it would be good to have a clear-cut, picture as to in which cases to suspect infection, in which cases not to, because doing a biopsy in an inflammatory or an immune-mediated scleritis may be
Yes.
counterproductive.
yes.
Also, the disease itself can produce thinning. The scleral or scleritis can produce or will produce thinning of sclera over a period of time.
Yes.
Thank you.
Thank you.
Next presentation by Vijay. Vijay Shetty. Is he here? All right, he's not here. So Tina Marriott? Presenting authors. Okay, Sri Vaishnavi. Okay. Sri Vaishnavi, sorry.
We'll request the next speaker to be ready.
Good afternoon, everyone. Today I'll be presenting my poster on antibiotic susceptibility patterns and biofilm formation of pathogens causing ocular surface and adnexal infections. To start with, knowing the etiology of eye infections and their local sensitivity profile is important for us to guide and select the initial antibiotic therapy and also optimize our management. Why is it important? Inappropriate and irrational use of antimicrobials provide favorable conditions for these resistant microbes to emerge, spread, and persist. Additionally, biofilm formation also increases the antimicrobial resistance. So, my aim of the study is to assess the bacterial profile, get the antibiotic susceptibility and sensitivity of these ocular surface pathogens, and also understand their biofilm forming potential. So, this study was done in a tertiary care center in India, which is a prospective cross-sectional study where patients presenting to the outpatient department with ocular surface and adnexal infections were taken into consideration. Children below the age of 18, patients not willing to participate, and patients who were on antibiotic therapy 5 to 7 days prior to presentation were excluded. So, as soon as a patient presents with ocular surface or adnexal complaints, the socio-demographic and clinical details were noted, appropriate samples were collected and sent for gram staining, blood agar, chocolate agar, and antibiotic susceptibility based on Kirby-Bor disc diffusion method using CSLI guidelines. If they were turned positive, a 96 flat bottom microtiter plate was used for biofilm formation potential. So coming to the sample size, I've got 87 samples, out of which only 41.3% had bacterial growth, 7 had fungal growth, and 50.5% had no growth. Now coming to the organisms that were isolated, gram-positive were more common, among which Staphylococcus aureus was 19 out of 21 samples that were noted, and among the gram-negative, Pseudomonas was also the most common. We've also got some atypical organisms like Citrobacter and Morganella in our isolates. Now, coming to the antibiotic susceptibility among the different organisms, if we see Staph aureus, they had a resistance pattern of 94.7 for ciprofloxacin and levofloxacin, a 52% resistant rate for moxifloxacin, and erythromycin of a resistance of 21%. Now, if we talk about Streptococcus, Streptococcus showed a sensitivity rate of 100% in case of ciprofloxacin and levofloxacin, whereas it showed 100% resistant for erythromycin. The biofilm forming potential of Staph aureus was around 42%. Now, coming to the gram-negative organisms, I'm going to generalize all these organisms in total. So, their resistant rate for ciprofloxacin was about 40%, and that of amikacin was 26%, and that of tobramycin was 12%. If you see Pseudomonas, Pseudomonas had a resistance pattern of 25% for ciprofloxacin. So, a similar study was done in southwest Ethiopia, where they found that ciprofloxacin and gentamicin had better activity, and coagulase negative staphylococcus followed by Staphylococcus aureus were more common, and in gram negative there was Pseudomonas and Klebsiella that were more seen, and the biofilm forming potential was maximum with Pseudomonas followed by Klebsiella and cons. So, it is important for us to understand and use antibiotics rationally in order to maintain their effectiveness for future use. These are my references. Thank you.
No, it's okay. I think it was a very good study because we all need to take this take-home message that just don't give antibiotics everywhere. So that's very nice.
How does it compare with the standard culture positivity rate across India? Your study versus the others?
So there was one study that was done, which was a retrospective study. So 2005 to 2020, they have collected all the samples. So they had about 5,000 samples, out of which 1,000 samples had positive bacterial growth. In that, they showed that 50%, around 50% resistance to all the fluoroquinolones that we are using. So that is.
Thank you.
Thank you so much.
Good afternoon,
Yeah,
everyone.
please go ahead.
I will be presenting on the correlation between clinical features and the histopathological characteristics of a primary pterygia. Pterygium is defined as a growth of fibrovascular tissue from bulbar conjunctiva onto the cornea. Extension of the pterygium over the cornea and its fleshiness vary widely among individual to individual. Correlation between histopathology and clinical features is not addressed widely and is important for understanding the pathogenesis. The present study, it was designed to evaluate the correlation between the same. This is a prospective interventional study from April 2023 to November 2024 in about 100 eyes with primary pterygia. All the patients with pterygium undergoing surgery for decreased visual acuity or cosmetic reasons were included in the study, whereas pseudopterygiums or coexisting conjunctival diseases and patients on prolonged topical medication for pterygium were excluded from my study. Complete comprehensive ocular examination was done, including slit lamp biomicroscopy, photography, and dimensions on the cornea were measured. The length was taken as the distance between the two opposite edges of the pterygium intersecting at the limbus, whereas the width was taken from the edge of the pterygium apex to the plica. Plica similaris present or obliterated was assessed. Redness and fleshiness were graded from grade 1 to grade 3, both. The excised pterygium samples were sent for histopathological analysis and were analyzed by a pathologist. The characteristics that were included vascular density, vessel count in high power fields, vessel count, subepithelial and stromal fibrosis, stromal elastosis, and leukocytic infiltration. The study included 100 eyes with a mean age of 51. Mean dimensions, the length was 5.45 and width was 11.3. Redness in the pterygium was graded as grade 1 in 32% of the eyes, grade 2 in 33%, grade 3 in 35%, and fleshiness T1 in 34%, T2 in 36%, and T3 in 30%. Coming to the results, as there was a positive correlation between the increasing length and width with the grade of the redness and fleshiness of the pterygium. There was also, with the increasing grade, there was more redness and more fleshiness seen. Also on histological correlation, there was vascular density, stromal fibrosis, and leukocytic infiltration and stromal elastosis, which were found to be significant. This is a picture which shows diffuse redness with on histopathology showed increased vascular density and fleshiness, which demonstrated stromal fibrosis. Positive association between lesion dimension, redness, fleshiness, and vascular density was also reported by Redda et al. Our study showed stromal elastosis in about 50% of the cases, which could be related to various environmental factors. Stromal vascularity and fibrosis show significant clinicopathological correlation. Stromal vascularity is an important and a promising therapeutic target, especially in patients who come for cosmetic complaints. This could be a valid reason for use of anti-VEGFs as a target therapy for pterygium, reduction in vascularity, and decrease the progression of the pterygium. Studies have shown positive histochemical staining of VEGF in the wall of the blood vessels in all the studied lesions. This study correlates many histopathological variables answerable for the difference in the nature of the pterygium. It can help plan new therapeutic agents to reduce vascularity and fibrocollagenous multiplication. Pre-treatment classification based on size, texture, vascularity of the pterygium may provide a prediction for postoperative recurrence rate. Thank you.
So you people took the grades, different grades, grade
Yes.
1, 2, 3.
Yes, sir.
And then the histopathology.
Yes, sir.
So it is quite obvious. More severe,
More,
findings.
yes, sir.
So therefore, what is the new findings that you think this study tells?
So-
or did you do immunohistochemistry on these?
No, sir. So there's very few studies which actually show the correlation between the histopathology and clinical features. So we just wanted to know if there was a chance where we could, because what our findings showed was there's a lot of vascular density in all the pterygium samples that were sent. So if we do use VEGF as anti-VEGF as an adjuvant to surgery, it might also reduce the recurrence rate of the given pterygium.
So I think we've already a lot of work has been done with anti-VEGFs and pterygiums. So I mean,
Yes,
what would
for-
you have really gained with that? I mean, that's something that I was wondering. Anyway,
Yes.
thank you.
Thank you.
We'll call the next person, please. Yeah.
Dr. Bhagat, please go ahead.
चल नहीं रहा है? Is it moving?
It's not displayed over there.
Don't worry.
Can you start the
You speak.
Good afternoon. My
Projection,
topic.
please.
Now it is started. Okay. Good afternoon. My topic is differentiating dermolipoma from subconjunctival fat prolapse on magnetic resonance imaging. So, it's not working. So for starters, differentiating ocular dermolipoma versus subconjunctival fat prolapse. Ocular dermolipoma is basically normal tissue growth in an abnormal location. It is basically contains the connective tissue and adipose tissue at the temporal fornix. It is a yellowish white small mass adherent to the conjunctiva, and usually it is asymptomatic, usually detected in adulthood. It is an uncommon benign tumor constituting about 4.2% of all conjunctival lesions. It is congenital and it occurs in and under the bulbar conjunctiva, usually at the temporal fornix, that is at the lateral canthus between the superior and the lateral recti. It is a congenital, basically choriostomatous tumor. The symptoms can be something as basic as mechanical irritation, but it can also progress to larger size lesions, which may cause astigmatism, and also the cosmesis is also a factor. Versus the subconjunctival fat prolapse, which is basically an acquired lesion due to herniation of intraconal fat due to weakness of the Tenon's capsule by aging, trauma, surgery, or a combination of these factors. The fat which is mainly responsible for the neurovascular integrity and which is also provided by the tenons, that all may be affected and it may lead to the prolapse into the subconjunctival space. It is contains the fat, fibrovascular septae, and inflammatory infiltrates. It is seen in elderly obese men and presents as a fat-containing epibulbar mass, again in the lateral canthal area. Anterior margin is convex and may show the presence of fine blood vessels. The common point between both of these is both are located superotemporally and do not involve the cornea. So I'm going to be presenting a case of unilateral dermolipoma in an otherwise healthy adult male and is to be differentiated from a subconjunctival fat prolapse. A 60-year-old diabetic patient who's with uncontrolled sugars was presented with a superotemporal swelling of size 2 cm to 1 cm in the right eye, which is soft, cystic, yellowish, freely mobile, non-tender, having convex anterior margin with superficial fine blood vessels. It showed prominence on convergence. There were no other factors like redness, pain, watering, no history of trauma, discharge, any ocular surgery in the past, or any ocular usage of any topical medication. No other systemic features. The aided visual acuity was 6.6. The anterior segment and posterior segment were both evaluated along with a dilated fundus examination, which was also essentially normal. A provisional diagnosis of dermolipoma or subconjunctival fat prolapse was made. As you can visualize in the images also, the typical lesion is what we can observe. This is the basic, the visual acuity could be 680 and improving to 6.6, and the projection of rays was accurate in all the 4 quadrants. The refraction is provided. Rest of the anterior segment was normal. Only the conjunctiva showed a superiotemporal, palpable, and fornical well-defined swelling near the lateral canthus of size 2 cm into 1 cm in the right eye, which was cystic, soft, freely mobile, non-tender, and had superficial fine blood vessels. The rest of the anterior segment was normal. The intraocular pressure was 14 millimeters of mercury in the right eye and 16 in the left eye on a Goldman application tonometry. The fundus was also normal. The MRI imaging that was done without contrast showed a well-defined altered signal intensity of 1 centimeter into 0.3 centimeter at the superiotemporal aspect of the right epibulbar area. The important point being it was not continuous with the intraconal fat, and a sliver of well-defined crescent-shaped lesion was observed, which was hyperintense on T1, T2, and hyperintense on T2. Rest of the orbits, optic nerves are within normal limits, so we confirmed the diagnosis of dermolipoma. So the diagnosis of the patient was in a case of diabetes mellitus 2. It was a refractive error with dermolipoma in the right eye, and left eye was nucleus sclerosis grade 1 with cortical cataract with refractive error. Management of the patient included the investigations and the management. The systemic investigations were done. Yes. So basically, we did the conservative management of the patient and the proper refraction and lubricants, and he was asked to review. So basically, we need to differentiate between the two because the location and the presentation is quite similar, but we can differentiate on the basis of the magnetic resonance imaging. So in our case, it was dermolipoma because the treatment of both is different, and we need to accordingly identify the same. Total excision is contraindicated in the case of dermolipoma. So basically, we need to identify all the conjunctival lesions and other ophthalmologic anomalies, especially in the patients, diabetic patients especially, and these are my references. Thank you.
Thank you. So what is the value of doing MRI? What was the indication?
So basically, both these lesions, like I said, they have a very similar presentation. So to identify whether it is
How does it make a difference? आपने तो conservative ही करना है.
yes, sir, but if it
so
was
see, the MRI or whatever the diagnostic test you do, it is going to cost.
Yes.
So therefore, if we are not making a major decision about treatment or prognosis, then maybe investigation is necessary or not, something that you should question.
And it may not be correct to say that MRI confirmed the diagnosis of dermolipoma because any of these diagnoses is ideally histopath. So confirmation never happens on imaging. Clinical correlation is needed.
I think that's a very valid point, sir. I mean, like, we have to think of the economics of the patient. But thank you.
Thank you very much.
thank you, thank you, sir.
Next.
Dr. Apurva Ocha.
Hello. Good afternoon, everyone. I am Dr. Apurva Ojha, and here I am presenting a case series of infectious scleritis. There were 3 patients. Out of them, 2 cases have similar finding. In case 1 and 2, both of them presented with history of redness, watering, and severe pain. In the second case, there was a history of trauma along with the symptoms. Best corrected visual acuity in case 1 was 6/12 and 6, and other case 6/9 and 6. Pupils were normal, and anterior segment shows diffuse scleritis with whitish pointing lesion which were changing its places. In the second case, sclera showed true granular white nodules of 3 mm with scleral thinning and uveal show. In both the cases, we have started them on antibiotics, steroids, and a cycloplegic. Investigations like ESR, CRP, BSL, and P-ANCA, C-ANCA, and chest X-ray sent. Tuberculin test was also done, and all the tests were negative. This was done to rule out the autoimmune causes. After the physician clearance, steroids were started. In case 1, you can see the pointing lesions, and the cornea were showing fine non-pigmented KPs, and there was no reaction in AC. In case 2, there were 2 granular white nodules of 3 mm size, and there was scleral thinning and uveal show present. Cornea was clear. In case 1, we have taken the discharge and sent them for gram stain, ZN stain, and KOS smear preparation, and fortified amikacin drops were started along with steroids. Culture showed Klebsiella pneumoniae, and along with amikacin, ciprofloxacin tablets were started. In case 2, there was worsening of symptoms, so we decided to go for nodular scraping. Nodular scraping showed gram-positive filamentous bacilli nocardia. So we started the patient on sulfamethoxazole and trimethoprim combination along with topical amikacin eye drops. Patient responded to the treatment and now patient posted for scleral patch and graft. Case 3 was slightly different. Presentation was similar, but best corrected visual acuity was 6 by 6 parts and N6. All the autoimmune workup was done, and along with that, tuberculin test shows necrotic induration. Infectious disease expert opinion taken, and HRCT chest showed mediastinal lymphadenitis. EBUS and TBNA was done on bronchial lavage, and gene expert shows MTB. So AKT was started. Symptoms were relieved, and now the infectious scleritis with uveal show is present in the patient. For the discussion part, we must keep differential diagnosis of infectious scleritis in mind. Nearly 50% of the cases are associated with collagen vascular disease, and infectious disease is rare. In case of infectious, there must be history of trauma or ocular surgery. In case of non-infectious, autoimmune diseases may be present. Infectious disease, direct invasion of the pathogenic organism. In case of non-infectious, collagen vascular disease. Clinical features may show purulent exudate in case of infectious. In case of non-infectious, diffuse or tender congestion of the deep vessels present. Diagnosis may be done by biopsy. In case of non-infectious, blood tests for autoimmune workups must be done. In case of infectious, antimicrobial therapy along with steroids can be given. In case of non-infectious, immunosuppression is required. Most common organisms are Pseudomonas, Klebsiella, and Nocardia. Bacterial infections tends to present more acutely, whereas infections due to fungi, Nocardia and microbial are more indolent in onset and presentation. Debridement of infected nodules or ulcer may be done for the definitive diagnosis. An early clinical suspicion of the infectious origin, identification of the infecting organism, and appropriate medical and surgical therapy could have good tectonic and visual outcome. Thank you.
Very nice cases. I think the fundamental clinical differentiation between infectious versus non-infectious is the infectious scleritis will present with a little bit of discharge and abnormal maceration of the tissue, while immune-mediated scleritis very neat, clean, usually not associated with discharge.
Yes.
Very good case series. Thank you. Any
Thank
other
you, sir.
questions? Thank you.
Thank you.
Next presenter, Pratik.
Sure.
Thank you.
So for a moment, let us come out of clinics and look at the larger picture. Can we have the slides, please?
मैंने सोचा आप meditation के लिए बोल रहे हैं. Let's come out of clinics and do a meditation.
Slides, please. Okay. So esteemed chair, ladies and gentlemen, thank you for the opportunity. No financial disclosures. So accidental chemical injury to the eye may occur from lime, paint, superglue, cleaning agents, pesticides, industrial solvents, and environmental pollutants. Published literature has infrequently reported such an injury due to inappropriate topical application of a traditional medication. I'm presenting a series of 2 patients who presented after inadvertent ocular administration of a topical lotion containing salicylic acid, benzoic acid, and alcohol named Dadurin, which is marketed as a traditional medication for dermatological conditions. After exposure, both patients had washed the affected eyes immediately with tap water, and both patients were carrying the bottle of the incriminating agent at the time of presentation. This happens to be the particular medication. The box of the medication, which is mentioned, indicated in ringworm and tinea in Hindi. B shows that the composition of the medication and the labeling on the box is poison. C shows that the particular medication is packaged in an eyedropper bottle, and D is about the same, the labeling on the bottle, which is similar to what is found on the box. So case 1 was the 28-year-old male who presented with redness, mild pain, watering, and swelling following a drop of Dadurin in place of olopatadine. The visual acuity was all right, as was the examination overall, but then a corneal epithelial defect 3 mm into 2 mm was seen, straddling the limits from 5 to 7 o'clock in the left eye. A Roper Hall grade 1 or a Dua grade 2 ocular surface burn was diagnosed. The next case is of a 56-year-old female who presented with similar complaints after installation of Dadurin 4 days ago in place of brimonidine plus timolol eye drops. The unaided visual acuity was 2/60 in the affected eye, And on examination, there was eyelid edema, matted eyelashes, conjunctival and ciliary congestion, and chemosis with confluent corneal epithelial loss in the right eye. Part of the visual acuity was affected due to immature cataract as well. So moxifloxacin, lotipretinol, and carboxymethyl cellulose were prescribed for 2 weeks in both affected eyes, and anti-glaucoma medication was switched to a preservative-free solution. At 2 weeks, the symptoms inside had improved, and the epithelial defects were found to be healing satisfactorily. Subsequently, the eyes achieved normal epithelial integrity, and there were maintained on lubricant eye drops. Both patients were symptom-free at 2 months of follow-up, and now 6 months of follow-up. So ocular wounds comprise about 7.7 to 18% of all ocular traumas, and they are a major cause of visual morbidity. Previous studies of accidental chemical injury to the eye are limited to household or industrial agents, with occasional reports incrementing formulations of alternative system of medicine, particularly Ayurveda. Only 2 earlier reports of ocular surface injury with salicylic acid-based chemical formulations were found in published literature. So our patients admitted that the similarity in packaging between this medication and routinely used eye drops was a cause of confusion, which is likely why they instilled this agent into the eye. So the drugs that look alike but are intended for different recipients carry such risks when stored together in pharmacies and households. Previous case reports have recommended the packaging of salicylic acid-based medicines to be easily distinguishable from eye drops. However, manufacturers of these medications have not modified the packaging accordingly. Patients with low vision may have added risk of self-induced chemical injury. We all know ocular surface injury from dilute salicylic acid can be mild to severe and may require surgical intervention and may culminate in nebulomacular corneal opacities and vision loss as well. To conclude, drugs that look alike due to similar packaging can result in ocular medication errors, and therefore this case series highlights that the importance of distinct packaging of these medicines which are hazardous to the ocular surface. Thank you so much.
Very nice. Why they have the similar eye bottles? This comes as Dauterine as an ointment or a drop?
A drop, sir. It is a lotion for tinea and ringworm. It is alternative medication. Part of it is a policy issue because there is no regulation on the part of the government how these traditional medications should be packaged. And there is no input from, say, societies like AIOS and, say, optometry associations or maybe pharmaceutical associations or maybe associations of pharmacologists. There is no recommendation to the government. So this is the larger picture, sir.
I just had a question, sir. In fact, I was wondering that when you all knew that, this was a particular agent, a chemical agent which had given this particular clinical condition, why did you all go in for a steroid and an antibiotic also, and especially an antibiotic which also had known epitheliotoxic propensity? And why did you not just go in for a plain simple lots of, let's say, lubricating agents?
That could have been one line of therapy. I agree. Withdrawing the incriminating drug, yes.
Yeah, but topical steroid and antibiotic are usually given for acute chemical burn. Prophylaxis, but steroid mainly to control the inflammation.
Yes.
Maybe that's Dr. Sagarika is a old book teaching that in presence of epi defect, don't give steroids. So the context is different.
Actually, I'm not talking about. I'm talking about that you're giving an antibiotic, and an antibiotic which also is known to cause epitheliotoxicity. So if you are giving something which is already your corneal epithelium is damaged, then you're giving something epitheliotoxic, and then you're giving a steroid which is for I realize that yes, inflammation we would prefer to give let's say low T, you only given a very, very low, but to give an epitheliotoxic drug is something that occurred to me.
Yes, okay, ma'am.
Thank you.
Thank you.
All right, next please. Ritika.
Ji, sir.
Yeah, please go ahead.
Good afternoon, everyone. Myself, Dr. Ritika. I'm presenting a case of 5-year-old male boy whose parents complain of swelling below right lower lid for 3 months, caused due to injury by wooden stick. The swelling was non-progressive. There was no pain, redness, or any discharge from surface. Their only concern was cosmesis. On examination, it was 0.5 into 0.5 centimeter globular swelling below right lower lid, which was freely mobile, non-tender, not adhered to skin or bone, and ocular movements were full and free in all cases. Anterior segment examination was normal. Posterior segment examination was also unremarkable with no changes in the fundus. So the question was, what can be this cyst? Could it be a dermoid cyst, a lipoma, or any parasitic infection? Or it can be a tumor, malignancy, or as there's history of trauma, could it be myositis or any abscess? Ultrasound was done and it was found it was a well-defined cystic lesion with eccentric echogenic nodule within it involving the muscular belly of right orbicularis oculi. So it is myocystisarcosis, but it is a first case up till my knowledge in which the myocystisarcosis is found in orbicularis oculi muscle. It is very rare in extraocular muscles and it is mostly found in superior rectus. MRI brain was done with orbit to rule out the evidence of neurocystisarcosis and there was none. Excision biopsy was done under general anesthesia and in toto excision of cyst was done and sent for biopsy. Histopathological examination suggested a parasite with irregularly shaped membranous folding and scolis resembling the larval stage of cystisarcus larva. The underlying fibromuscular stroma also shows dense inflammatory infiltrate, hence confirming the diagnosis of cystisarcosis. Patient was given post-op syrup albendazole, steroids, paracetamol, and eye ointment tobramycin, local application thrice daily for 6 weeks, and then the steroid was tapered in the next duration of 4 weeks. Thank you.
And what was the symptom of the patient?
Only cosmesis. The only concern of parents was cosmesis, sir. There was no pain, nothing.
So how would your management have changed if there was neurocystisarcosis? You said that you did the MRI.
Yes, ma'am.
And you didn't find evidence of neurocystisarcosis. Why we did the MRI and what would have happened if there was?
If there was any evidence, then we would have involved steroid.
Would you have still gone ahead with what you did?
No, ma'am. First, we would have given a course of steroid, and then we would have gone for surgery.
Any role of albendazole pre?
Yes, ma'am.
Pre-surgery. And did you also do any systemic investigations?
Yes, ma'am. The child was operated under general anesthesia. Systemic investigations were done.
What systemic investigations?
CBC was done. CBC, RFT, LFT,
And?
chest X-ray, and ECG.
And?
Not as much.
Basic investigations? Stool?
No, ma'am. It was not done.
So even eosinophilia would be a feature of cystisarcosis.
Yes,
That also can give way.
Thank you.
Thank you.
Yes, Sanchita.
Good afternoon, everyone. My topic is dry eyes in diabetes mellitus patients and its association with diabetic retinopathy. Diabetic retinopathy stands as a marker of generalized macrovascular disease, while corneal neuropathy acts as a tool to predict peripheral and autonomic neuropathy and hence gives an opportunity for early treatment. Diabetic complications have been recognized in cornea as indicated by alterations of immune cells in cornea. It causes decrease in tear secretion, corneal sensitivity, and poor adhesion of regenerating epithelial cells. So the present study was undertaken to evaluate corneal surface in diabetic individuals and risk factors attributable to dry eye. And furthermore, an attempt was made to find any correlation between diabetic retinopathy and dry eyes. So this was a cross-section hospital-based study which included 150 patients for a period of 18 months. All patients of either sex and all age groups diagnosed to have diabetes of any duration were included. Patients with local disease and systemic diseases like other than diabetes mellitus, which are known to cause other ocular surface abnormalities. Patients on local or systemic medication, which are known to cause other ocular surface disorders. Chronic contact lens users and history of previous ocular surgeries. These patients were excluded. So after taking an informed consent, detailed history, which included a questionnaire about dry eye, and a detailed ocular evaluation was performed, and an anti-segment examination under slit lamp was included, which included meibomian gland status, corneal sensation, tear meniscus height, tear breakup time, torsion staining, and Schirmer's test was performed. Fundus examination with both IDEO and 90D slit lamp biomicroscopy was done, and retinopathy was classified into mild, moderate, severe NPDR and proliferated diabetic retinopathy. Dry eye was graded into 3 types: mild, moderate, and severe, which was based on Schirmer's test, TBOT, and corneal staining. So the results included a total of 150 diabetic patients, which had 50 patients were type 1 diabetic and 100 patients were type 2 diabetic. Majority of the patients were in the range of 11 to 20 years in type 1 diabetic age group, and while majority of type 2 patients were in the age group of 51 to 60 years. So the total prevalence in type 1 diabetic patients was 32% of dry eyes, and type 2 had 38%. Total prevalence of dry eyes in these diabetic patients was 36%. The statistically significant correlation seen in dry eyes and diabetic patients was with fasting blood sugar and postprandial blood sugar, which was less than 0.01% significant, which was showing that there's an association of glycemic control with dry eyes. Then in risk factors which was prevalent in diabetic population with associated dry eyes, it was mostly seen in patients with meibomitis and reduced corneal sensation. As we can see here, the p-value was less than 0.01% in both these categories, with an odds ratio of 6.57 and 21.31 in respectively in meibomitis and reduced corneal sensation. Again, coming on to the test, we had 32% of the patients had abnormal TBOT, 22% had Schirmer's test abnormal, and 19.3% had Schirmer's test with anesthesia abnormal, and fluorescent testing was 20% abnormal in these patients. Overall, there was no statistically significant correlation between retinopathy except in cases of high-risk PDR. But again, there was only 1% of one patient with high-risk PDR, so we cannot. It was statistically significant, but we cannot really interfere that it was statistically significant that way. Overall. So my conclusion is that poor glycemic control was associated with 1.91% times increased. Showed increased risk of dry eye. Other significant risk factors included hypertension and prior laser treatment. Reduced corneal sensation and meibomitis are also major risk factors. Abnormal TBOT was present in 32% of patients, while decreased tear secretion and basal secretion was noted in 22% and 19.3% respectively. A statistically significant association was found between high-risk PDR and dry eyes. But the limitation of my study is that it was a small sample size of 150 patients. Thank you. The time period was a little concise for me, so and I could not get really patients with who had a good follow-up. So that is why we had patients lost to follow-up, and I could not include them in my study. That's why I had a small sample size.
What is the mechanism of dry eye in diabetic patients?
So it can be because of hyperglycemia, it can be because of insulin deficiency, and it can also be because of inflammation. All these three factors can lead to dry eyes. So the key factor is insulin deficiency only. Hanji sir.
Because they develop hypoanesthesia.
Yes sir. So hyperglycemia. Because of hyperglycemia that leads to neuropathy.
So neuropathy क्यों होता है? So if you understand why the neuropathy, then you probably won't take at this corneal anesthesia.
Yes sir.
As a risk factor.
Yes sir. Yes sir.
They the same mechanism.
That is the same mechanism. Right sir.
All right.
Okay.
Thank you.
Thank you sir.
Next person, please, Dr. Rajesh Nayak. Presenting author, Dr. Vindhya. Dr. Vindhya. Absent?
Dr. Anup Kumar Goswami.
Good afternoon, chairpersons and esteemed colleagues. I shall be presenting a case of limbal vernal keratoconjunctivitis, which troubled us because of unusual presentation. Classically, VKC is described as a seasonal recurrent bilateral allergic inflammation of the conjunctiva with three clinical subtypes, namely palpable, limbal or bulbar, and the mixed type. Diagnostic criteria include tarsal or limbal papillae of 1 millimeter or more in diameter with itching and at least one of the following symptoms in the last 6 months. The aim of this presentation is to report a rare case of VKC with an unusual presentation, thereby increasing awareness and preventing wrong diagnosis. A 19-year-old male construction worker presented to us with the complaints of redness and itching both eye for 8 months. And the recurrences were there. He had taken treatment elsewhere, but he was not happy. And there was no history of foreign body or any associated skin allergy or asthma. Examination showed bilateral hypertrophied bulbar conjunctiva with congestion at limbus in the nasal and temporal region between 2 and 5 o'clock hours and 7 and 11 o'clock hours respectively, extending 3 millimeter nasally and temporally from the limbus in the wing-shaped fashion as you can see in the picture. There was some pigmentation temporally in both the eyes. There was minimal upper tarsal congestion without any papillae. Visual acuity was 6/6 both eye unaided with clear cornea and quiet anterior chamber. Rest of the ocular examination was normal. A provisional clinical diagnosis of limbal vernal keratoconjunctivitis was made and the patient was started on topical fluoromethalon 4 times a day. And because of this atypical presentation, we reviewed the literature and which we shall take up in the discussion. And a final diagnosis of segmental limbal vernal keratoconjunctivitis was made. And the patient was relieved of his symptoms after a week of treatment, and olopatadine 0.7% was added, and the fluoromethalon was tapered over the next 3 weeks. As we all know, etiopathogenesis of VKC involves immunological factors with type 1 and type 4 mechanisms both taking part. Additionally, we have environmental factors such as sunlight, heat, dust, and eye rubbing as additional factors which play an important role. Conventionally, limbal VKC is characterized by broadening and opacification of limbus, producing thickened appearance of limbus, starting first in the superior limbus and then spreading to all around 360 degrees. Increase in environmental temperature is one of the factors that exacerbates the limbal disease, especially as described by Tuft. Few authors have reported that limbal vernal keratoconjunctivitis can manifest as an isolated mass with or without tarsal involvement. Histopathological findings of the limbus mass lesion suggest response to chronic allergic stimuli rather than any squamous neoplasia. And in Asian patients, conjunctival pigmentation has been reported as was seen in our case. Hernandez et al. Inferred that occupational exposure can induce allergic manifestation of the eye, and limbal forms can lead to stem cell deficiency resulting in chronic ocular surface inflammation. Keeping this literature in the background, we also inferred that bilateral, almost symmetrical wing-shaped hypertrophic lesions involving a segment of limbar and bulbar conjunctiva nasotemporally, which has never been reported previously, and we coined the term the segmental limbal vernal keratoconjunctivitis. And the proposed reason for this unique presentation in our case is probably occupational exposure of the conjunctiva to dust, debris, and irritant materials, along with heat, which was aggravated by frequent rubbing of the eyes, which resulted in inflammation and tissue remodeling in the exposed conjunctiva, finally manifesting as a segmental involvement. To conclude, the segmental limbal involvement is probably due to combination of chronic underlying inflammation aggravated by environmental factors and mechanical microtrauma. And in a patient where we cross isolated or multiple limbal lesions, possibility of limbal vernal keratoconjunctivitis should be suspected, and a segmental involvement of limbus is a rarity and should be considered to avoid any wrong diagnosis. Thank you.
What was the age at presentation?
He was 22.
It's quite uncommon.
Yes.
And then mass being present in the interpalpebral area is very unusual.
Very unique. That is and typically the wing-shaped presentation was quite.
So how do you know that it was VKC?
See, OSSN definitely comes as a differential diagnosis in this. So we started with the steroids and we kept him on observation. Then bilateral symmetrical lesions are very uncommon for an OSSN to manifest.
In xeroderma, it can happen. There was, like, if there is an atypical pigmentation on the skin or something, you should look out for OSSN as well. And what about pseudoepitheliomatous hypoplasia and not actually VKC?
Yes, that these definitely come under in differential
Because that
diagnosis.
would also respond to your steroids.
But we kept him on observation for next 3 to 4 months, and he was absolutely fine on olopatadine, and there was no itching also. The itching was also an important symptom which he had. His main concern was redness and itching. He was not very concerned.
Thank you.
Thank you so much. Thank you so much.
अपने लिए तालियां. Thank you. I think we are done with it.
Yes.
Hall attendant, if you can collect these papers, and we are done with the session.